So now I invite Dr. Neethu, Latiff, UVA consultant at Giridhar Eye Institute, to talk about approach to infective posterior uveitis.
Yeah. So starting with the sun classification of uveitis, posterior uveitis, when we call it posterior uveitis, when there's inflammation of the retina and the choroid. So it can be a retinitis, it can be a choroiditis, chorioretinitis or retinochoroiditis, neuroretinitis or retinal vasculitis. Now when you see a case of posterior uveitis, remember 4 R's. One is the clinical phenotype. So you can't confuse between a retinitis or a choroiditis, because retinitis points more towards infective etiology. The second is the reason, whether it is infectious or non-infectious. Third, is it real or is it masquerade? And fourth, is it a recurrence of the disease or a complication of the disease? Retinitis, as I told, there is more chance of being infectious. It can be focal. So when it comes to focal, the most commonest is toxoplasma retinochoroiditis, and a non-infectious etiology is Behçet's, which is sometimes rare to see. And multifocal or diffuse, you have the viral retinitis and post-fever retinitis. Now, how do retinitis lesion look like? So when it is a full thickness or inner retinal involvement, you see a bright yellow fluffy lesion with indistinct border. So the retinal vasculature passing through these lesions appears obscured, and it may produce moderate to severe vitritis. Now when it is an outer retinal inflammatory lesions, it becomes a dull orange or yellow with indistinct borders. Vasculatures may remain clear over the lesions. Vitritis could be mild or moderate. So see this fundus photograph of this patient. There is a yellowish lesion, a retinitis lesion, which is a foveal threatening lesion. So as you see, zoom in, you can see that the lesions are fluffy yellow with indistinct border, and the vessel is, you can see the vessel is obscured over the lesion. And you see the OCT, there is a full thickness retinitis lesion, retina is involved, and the underlying choroid is not involved here, but the choroid is not appearing, it's not appearing properly because of the retinal involvement. This patient is diagnosed as toxoplasma retinitis, and we give a intravitreal clindamycin and see the response to the treatment. Now, most of the time, toxoplasma present as retinochoroiditis. So this is one patient who presented with retinochoroiditis. You see the OCT, there is a full thickness retinitis, underlying choroidal hyporeflectivity and choroidal thickening, and a localized posterior hyaloid detachment. And you can see these rounded bodies, which are typical of OCT finding in toxoplasma retinochoroiditis. Also, toxo can present as satellite lesions. So what are satellite lesions? These are lesions where active toxo appears adjacent to a scarred lesion. So this is a patient with satellite lesion and frosted branch angiitis. Just look into the vessels of this patient. It is like 360-degree vascular sheathing. Now coming to the other etiology, post-fever retinitis. So post-fever retinitis is multifocal retinitis, and it is because of immune-mediated reaction to the pathogen, mostly a fever which has happened within 3 months. And as you can see, the retina, the OCT, there is a retinitis lesion here, and also the other eye, there is subretinal fluid, and you can see the hyperreflective dots in the vitreous, which are the features of post-fever retinitis. So identification of these clinical phenotypes is very important, because when you treat it appropriately, you get a better results. So this patient improved from 612 to 66 with oral steroids and doxycycline. Now this is another case, a 44-year-old man who came to us with a necrotizing lesion, a disc edema, a necrotizing lesion here, and multiple retinitis lesion. Some are along the vessel, some are distributed randomly. So we had a query whether it is toxo or retinitis. But toxo, we don't see these type of pointed retinitis lesions. So then I started on empirical antiviral for this patient, sent him for the blood reports, and this was the OCT picture where there's a full thickness retinal involvement. And within 3 days, there was a rapid deterioration. You can see now the lesions have become more confluent and there is a peripheral involvement, a circumferential spread. So no doubt this is a case of ARN. And we started him on IV acyclovir and then followed by oral steroids and oral antivirals, and see how beautifully the retina has responded to the treatment. Now, not always acute retinal necrosis present like that, but most of the time, when to suspect acute retinal necrosis. So when you see this type of anterior segment finding, where you see mutton fat, sudden onset, vision drop or pain and mutton fat KPs, you need to do a clear fundus examination. It's very difficult to do a fundus examination here because the vitreous is very hazy here, and we managed to take a photograph showing the acute retinal necrosis here. Coming to CMV retinitis, the Sun criteria classified CMV into wedge-shaped area of retinitis, hemorrhagic retinitis, and granular retinitis. So vitritis will be typically none to mild because mostly it occurs in immunocompromised patient. Now this is one of our patients with CMV retinitis in HIV. Here you can see the right eye. It shows a wedge-shaped appearance with the apex pointing towards the optic disc and massive hemorrhages over the retinitis lesion. So this is a wedge-shaped defect, which is otherwise known as the tomato ketchup or the pizza pie appearance. And the left eye, you can see the granular form of the CMV retinitis. And granular form usually affects the periphery of the retina, and it doesn't have much of hemorrhages. So this patient actually we treated with oral Valga and cyclovir, and he responded very well to treatment initially. But on follow-up, he had a recurrence of infection, as you can see in this picture. So we just worried whether it could be an immune recovery uveitis. And we extensively investigated again, and we came to know that we talked to the HIV specialist, and then we found that the patient is not receiving treatment for syphilis. He was syphilis positive. So then simultaneously we did treatment for syphilis, and see the OCT here. The retina is so thinned out because of the viral attack. And this is the final visit follow-up. And he's doing well with under control. And nowadays, I don't think CMV retinitis is more common in HIV. It is more common in SLE. And this is a patient with SLE with CMV retinitis, managed properly and doing well with treatment. Now, another entity is syphilitic retinitis. So the great mimicker, as you all know, it can have a varied presentation, but few are pathognomonic of syphilis. So that is a ground glass retinitis, along with these punctate precipitates, pre-retinal precipitates. So these are the pathognomonic of syphilitic retinitis. This one is a classic choroiditis. So to differentiate, these are multifocal choroiditis. As you can see, it is a deeper lesion, dull yellow color, and you can trace the vessels over it. And this is the FFA of this patient with early hypo and late hyperfluorescence. And this is actually the patient responding to oral steroids and ATT. Now, this is another patient with a granuloma and TB granuloma. So, how will you differentiate it from sarcoid granuloma? So, you see these hemorrhages over the granuloma because it has the TB granuloma is more VEGF driven. So, it shows these hemorrhages changes. And also the OCT showing a contact sign as well as a choroidal granuloma with SRF. ASPPC. ASPPC is acute syphilitic posterior placoid chorioretinitis. So this is one of the patient who presented to us. So you see the fundus, nothing can be made out. We did a AF, and you can see this hyperfluorescent hyper lesion here. And you see the OCT, there were actually hyperreflective materials over the RPE. So we suspected syphilis, and his TPHA was positive, and he's doing well with treatment. Now, the next thing you have to think in mind is about the masquerade. So this is one of the 69-year-old lady who presented with dense vitritis, and you can see these yellow lesions in the periphery. It was not looking so good, and we could not properly put into any disease. So then we thought what to do next. So then we waited for 2 weeks and then again did a with biopsy. And the with biopsy histopathology, we didn't get anything, but the MYD88 gene was positive. Now all that is yellow is not choroiditis or retinitis. See this picture, you see a yellow lesion here and you see a dark spot here. So what is this? This is actually a multifocal CSR. So this dark spot indicates a site where the leak is there. So this is another patient with multifocal CSR with RPE tract. Now, whether it is a recurrent or a complication, so this was one of the patients who came to us who has received IVTA elsewhere, initially was diagnosed as toxoplasma. You can see a fulminant retinal necrosis. So you have to think before you inject. So definitely you should be aware of the diagnosis and you should be clear about your diagnosis and then only proceed with any sort of injections in the eye. So my take-home message is think infection first in any posterior uveitis with focal lesions, vitritis or necrosis. Missing it can be vision threatening. And history with pattern recognition guide you to diagnosis. Treat early and specifically. Monitor closely for complications and recurrence. And when in doubt, refer early. Thank you.